Okay, I think we're running out of time, so it's my pleasure to introduce our final speaker, who's also from Australia, Dr. Rustem Dortel.
Thank you, Michael. So just running over time now, but let's talk about post-CABG CTO PCI. So CABG should be done only once, so it should be done properly. And nowadays we still do a lot of Lima plus SVGs. Ideally, it should be total arterial, and especially in young patients. There was a case shown today, 45 with Lima with 3 SVGs, which is probably not a good medicine. Development of bypass has been very slow, and somehow majority of centers got stuck still on version 1, while some other centers already in US doing totally endoscopic. And this is a couple, 20 years spent on Mars. And when they came back, the man who was cardiothoracic surgeon went straight back to work because nothing much changed. But the woman couldn't go back to work because she had to be retrained as we're really advancing fast. And CTOs post-CABG is a separate group of patients. They're a bit older, they have more diabetes, more bad kidneys. Their distal cap is exposed to systemic pressure. So distal cap is much harder comparing to CABG naive patients. Very important to know that. And important to know that when we send patients for CABG, that within 10 years, up to 50% of those SVGs will be blocked. That's very important. If the lesion is 90%, then within 12 months, 100% of those lesions become CTO native. That's why in young patients, when we select grafts, they have to be good grafts by good surgeons. And post-CABG cases, those CTOs are more harder themselves. So the overall, the lesions are harder. The patients are older, harder, and the question is then what we do when they come with a blocked SVG, or they have CTO and SVG is blocked. Do we try to do something about that? We published with my mentor that's probably the best option nowadays if you have a set of skills actually to consider opening the native, because trying to revive the old SVG is probably not the best option, because we cannot predict how long our results will be there. It's a bit different probably from the young SVG. If it's within 5 years, we always try to fix it. But when we talk about old ones, it's probably not the best. So let's go through this case. This is a 49-year-old man who came with an STEMI. He had 3 SVGs at age of 44. His right is a CTO, and his SVG on the right is the one that supplies right, and through the PL supplies the circumflex. His culprit is SVG to OM, and that was a skip OM, so that's gone. That's within 5 years. As I said, within 10 years, 50% of them will be either blocked or diseased, those SVGs. So he was chosen medical therapy, and 1 year later presents now with his last remaining. And remember, this is the one supplies the circumflex as well. So what would you do in this case? His left main LAD is fine. Circumflex gets supplied from the left as well. So they put 2 stents in SVG. But the thing is, when we do native artery PCI, if we do it well with IVUS guidance, we can predict our results. With SVG PCI, especially old SVGs, nobody can predict how long it will stay. So then 2.5 years later, he comes with symptoms, severe SVG ISR. Left system is still good, but he's symptomatic. He fails medical therapy, and eventually they decided to refer him to a CTO PCI, and they put 4-French femoral sheath. We have full range of 4-French diagnostic catheters, just to help us with the referral. That's a kind of our program does that. This is non-CTO operator, but he knows that it will be done. And then essentially I used this SVG as a retrograde conduit. That's another difference. You don't have just septals, epicardials, and post-CABG cases have a lot of epicardial options, more than CABG naive. But then you have also occluded, blocked, or diseased SVGs, which are the safest retrograde option, especially for the beginners. And even if you have a fully blocked SVG, even it's been blocked for 10, 20 years, provided there is a stump, there is quite easy way to cross it. And of course, for the beginners diseased, like this case is a good case to try to do retrograde. So then you just go ahead with the reverse cut. I'll just go through that. It's just routine PCI. Once you beyond the distal cap, it's a routine PCI. Like if you arrive to that point from the septal epicardial. And then this is rendezvous when you wire microcatheter inside the coronary, similar to tip-in in the guide. And then the case becomes antegrade. I was guided PCI with 2 long stents. This was from few years ago. Nowadays, I would put 1 stent and 1 long DCB. I do a lot of blended therapy now without trying to do a full metal jackets, but that was a few years ago. And then another important thing, once you optimize and after IVUS you take a picture, PDA doesn't have flow. Because that SVG is not bad enough, actually it has still telemetry flow. What do you do now? Do you wait for this SVG to die? It will die, but maybe it will not die as soon as it compromise your flow to your stents. So I decided in this case actually to stop the flow, competitive flow, and used a couple of coils to block off the flow. That's what we recommend. If it's TME3 flow, is actually to block it off. And then, of course, you have a much better antegrade flow, and you're more comfortable with the results. And that's completely blocked, so it's before and after. Now, total arterial CABG. This is another case from a couple years ago. I just did diagnostic non-STEMI, 8 years old. CABG was done 20 years ago, 5 grafts. 2 of them are Y grafts. And just comparing to the previous case of 45 years old. So obviously 20 years post-CABG, all natives are blocked. This is normal. CABG creates CTOs. But you have to make sure your graft's working long. And this is all 5 grafts are patent. This is the art of total arterial CABG. And some centers, for example, Royal Melbourne Hospital has been doing it for 20 years with very good results published. And the good thing about this, or no, not very good thing, post-CABG, total arterial, you don't get CTOs to be treated. While if your surgeons use Lima plus 3 SVGs, then it's kind of investment in your CTO program because they will come back to you and you need to treat that. That's why. And another good option, hybrid revascularization, is you do total arterial, 1, 2, 3 grafts, and for non-LED targets, you do stents, imaging guided stents. That's what we do in my hospital. So worst CABG, bad CABG with any SVGs, and anything with total arterial and stent is what we consider good. Now, on a separate note, again, CABG creates CTO cases, and what you do today with surgeons do with your SVGs, it's investment in your program in 10 years time. Now, let's look at the right coronary CTO post-CABG. It's very interesting, actually, those post-CABG cases, because they have so many different options, many different collaterals. And sometimes you need to do even triple access to understand this all. This is just schematics showing that you can go epicardial from Lima distal septals, you can go epicardial from circumflex to PL, you can use occluded or diseased SVG graft, etc., etc. So this is typical stump. This is interventional stump, tapered. If there is no stump, do not touch that because you can wire aortic wall and cause a major problem. Obviously, in preparation, surgical report important. If you have previous angiograms, important. And sometimes you have to do even triple arterial access when there are 2 different sources of collateral, typically for the right. Something comes from the circumflex to PL, something comes from the Lima distal LD to PDA. And you need to create a triple access, which is easily to do. You still have to do only 2 injectors with male-to-male connector and switch for retrograde option. Once you do a couple of them, it's not difficult, but really very useful. And talking about intervening via SVG, sometimes the easiest one, if colleagues already stented those SVGs, you can just go through that. You can do, if the surgeons all days used to leave some staples, very important. Now you can use Gladius EX, but typically in my training, it was always Pilot 200, typical CTO curve. And you have to drill with your fingers because that will create 20 rotations in one go rather than with a torquer, which gives you only 1 rotation, and you just drill through that. Time to time, if you have a resistance, if there is a valve there, you do what we call tattoo technique or like mini Carlino technique, where you soften and you delineate your vessel SVG architecture. And in our program, doesn't matter how old SVG was occluded, it took us about 8 minutes to cross those SVGs and to arrive to distal cap. This is a schematic of tattooing. And once again, it just shows you where the SVG is, because sometimes it's difficult to see, and it softens this as well. So after that, it goes. And once you arrive to distal and stamoid, sometimes it could be very ambiguous. Distal tip injection also help with retrograde injection now that follows, and then it shows you where to go next. And sometimes if angle is acute, especially happens if it's SVG on LED or SVG on OM, there are different techniques, there are different instruments you can use, such as dual lumen microcatheters, angulated microcatheters, and sometimes people put stent across the SVG to native. That's a really trap. They look good, but few years later when they get blocked and you have to do something, it's difficult. And then as I mentioned, there are different things to do. Miracle 612 wires are still very good wires to deliver things, microcatheters around the angulated corners. It's the strongest wire to support you. And then it's a combination of different techniques with distal tip injections that can get you through. Sometimes you don't have to do anything retrograde. You just put microcatheter to pacify where to go antegrade. And guide extensions, I use about 30-40 of all cases. It just provides support, especially if you non-supportive guide like GR. Trapliner is probably the best because you will need to change a lot if you have access to trapliner. I don't work with Stelflex, but it's one of the best. And this is post-CABG facts that you have to remember that you may deal with loculated tamponade. Think that it's post-CABG. If you think there is no pericardium there, it could be not forgiving. So I have also a nice case, but I think I'm out of time. Yeah. Thank you. Thank you for listening.
Okay, thank you so much, Rustam. Just one question for me. So we know that grafting chronic occlusions, the grafts fail, especially if it's vein grafts. So your hybrid approach, where you're saying if you have someone with triple vessel disease, maybe the LAD is not completely occluded, and you've got a right coronary artery that's occluded. Are you saying the best technique would be to stent the LAD and then you would fix the CTO because grafting the CTO is not so good, or?
It's an interesting question. It depends in the context. Let's say it's 80 years old patient. Yes, I probably will stent LAD and then do medical therapy for the right and see how it goes. If there are symptoms of ischemia, I may bring them back. If it is a 40 years old with severe LAD disease, especially if it's osteal disease, I may find a good surgeon to do mid-cap for him, and then again, say medical, etc., and decide on the right. Or if the surgeons can do lima to LAD, and then another arterial graft on PDA, if it's big dominant PDA, that may work well. So it depends. The problem is that my colleagues quite often just send for bypass. They never specify what bypass they want. And that's the reason surgeons often don't develop over the years. They do stay lima plus SVGs. So when I came 8 years ago back from fellowship, I had a lot of conflicts with a few surgeons. But eventually they understood that I'm demanding total arterial. And then we started to do hybrid now. And we work very close together because they know if there is a difficult case for them, they send to me as surgical turn down. There is always backup plan for them. So we're friends actually. Initially they thought I'm doing something bad,
Fantastic. Any other questions from the panel?
Yes, just a short question for you. You said that you open the SVG. Sometimes you open the SVG with the total occlusion. So because the SVG has a lot of debris inside there, so how do you prepare the patient and the lesion in order to get the vessel and the system, the vascular systems, tolerate with a lot of debris going down after you go for the ballooning and stenting?
So if it is just if it's thrombotic lesion, and especially if it's business hours, often I would go and open the native because thrombotically occluded SVG, that's the only indication for ad hoc CTO. If it's doable and if there is a program in the hospital for that. If there is no operator, the colleagues can just balloon, restore a bit of flow, put on heparin, and then a few days later we may still do the same approach. You're right. If it's thrombotic, it can cause distal embolization. But if you cross these thrombotic masses with Corsair, it doesn't cause embolization because you don't do any more injections through that. All your injections will be through the distal tip. Yes, if it is within 3-5 years, you can stent SVG, but then you have to follow up them. If it's not especially thrombotic, it's just atherosclerotic.
Yes, thank you very much. And I think I still have the question for the first presentation. I think Anfazir is still here. I think the for last question, I think. So I think that because after the decision CTO trial coming out, and then another trial is the ischemia. So a lot of CTO operators, they don't want to do so many procedure anymore because they select the lesion in order to open it up. So what do you think about the two trial, decision CTO and the ischemia?
I think like CTO is like the trial for bifurcation. I mean, it's always it's always in the detail of the trial. So I think most importantly for me is that for now anyway it's going to be symptom relief. So although the trials, like certain trials, shows no changes in mortality, but I think the symptom relief quality of life is very important. And also you need to look at the details of the trial because CTO bifurcation, they are very heterogeneous. It's not all the same. The amount of myocardium jeopardy, the supply, the retrograde, the collaterals, and all that. So I think that you need to see your symptoms and your patients and take it from there. Thank you.
Thank you.
I think I think it's time for us to wrap up. Is that right? So I want to thank all our panelists today. I know we were a bit rushed, and amazing talks by all the speakers today. I want to thank you. This is just part one of CTO. There's going to be a part two. So thank you for everyone for staying, and it is about half an hour late. So hopefully see everyone at the dinner tonight. Thank you.